Welcome. Thank you for joining to this webinar, Latent TB Infection, Montana's Final Frontier to TB Elimination. We're really happy that you joined us. My name is Emily, and I'm a program manager at the Curry International Tuberculosis Center. So we're just going to do some housekeeping things before we get started. First off, as you can see, this webinar is being recorded and will be archived on our website. So please look out for an email announcing when this recording will be available. And of course, all participants are put on mute so as not to disrupt the recording. If you have any questions or comments during the webinar, please feel free to share them in the chat. We'll have people monitoring them. Next, just the Curry International Tuberculosis Center. This webinar is produced by the Curry International Tuberculosis Center, which is part of the University of California, San Francisco. Our office is located in Berkeley, California, which is sort of funny, but here we are. The Curry Center is one of 4 of the TB Centers of Excellence for Training and Education and Medical Consultation. We cover the Western region of the US, which is shown in purple, and our region includes 17 jurisdictions as well as the US Pacific Islands. Our project funding. So this webinar is made possible through the funding by the Centers for Disease Control and Prevention through a cooperative agreement, and is a project of the University of California, San Francisco. If not, so the Curry Center is accredited by the ACCME to provide continuing medical educations for physicians, as well as continuing education by the California State Board of Registered Nurses. This webinar is approved for a total of 1.25 continuing education contact hours. And to receive these CEUs, you must register for the webinar, participate in its entirety, and complete the online evaluation, which will be sent during the seminar. So please, if you want to, you can sign in during the chat, as well as we have registration at the beginning. Today's faculty have all signed the Declaration of Disclosure and have indicated that they have nothing to disclose. Additional information can be found on our online material folder. These are our learning objectives for our webinar today. Again, you can also find this on our materials folder online. And as you can see, we have a full agenda, and I've included some time at the end of the presentation for question and answer. So without further ado, I'd like to introduce today's facilitator, Ryan White. He is a communicable disease epidemiologist at the Montana Department of Public Health and Human Services. He attended both undergraduate and graduate school at the University of Utah in Salt Lake City, and earned his bachelor's degree in health, society, and policy, and master's of public health degree with an emphasis in epidemiology and biostatistics. He is currently the tuberculosis program manager and controller for Montana, and has been there since January 2018. So handing it over to you, Ryan.
Thank you, and welcome everybody. Really excited to have this hit the ground running here. So I'm just going to provide a quick epi update for TB in Montana, and kind of a quick national perspective. I've included quite a few slides that I'm going to go through very, very briefly and quickly, but I wanted to include them for reference, and the link is also included in the resources at the end of my slide set. But wanted to go over these perspectives so that you can see how Montana differs from the national scene. So for 2020, there were a total of 7,174 new TB cases that were reported. And this was a bit of a drop from what we had seen in previous years, and mainly that's been attributed to possible underdiagnosed cases, and it'll be interesting to see what we see in the coming years if that case rate kind of pops up. But the important thing to notice here is the kind of that distribution there, that 71, over 71% occurred in non-US born individuals, and 28% occurred in US born. And then 60% of those non-US born individuals were diagnosed 10 years or more after they had been here in the United States. So individuals that had, had a latent infection and then progressed to disease later in life. So real quickly, some of those top countries of non-US born individuals: Mexico, Philippines, India, Vietnam, China, kind of the heavy hitters. Race and ethnicity at the national level: Asian, Hispanic, Latino, African American, and then a smaller percentage of white and American Indian, Alaska natives. And then, as we see from the age distribution here, kind of our largest demographic there is that 25 to 64 and up, and then predominantly males are more impacted. This is just kind of interesting. There are 4 states in the country that have a majority of the cases that we see in the U.S. So it can be interesting when we have, say, homeless individuals that visit from one of these states. We have had that be a factor in the past, so something to just keep in mind. And then really the reason I wanted to include this slide was to show that 88% were not recent transmission. So a large majority of the cases that we see in the United States are not due to recent transmission. So here's Montana's context. 100 years of data, which is kind of cool to look at. Glad we're not in the 1920s or 30s, but we've come a long way, as you can see. But getting that last little jump to elimination is still requiring some effort on everyone's part. So this is US versus Montana's incidence rate. You can kind of see how the United States rate has really plateaued over the past 10 years. And Montana's kind of in the same boat, where we average 4 to 5 cases a year and have been for the past 10 or so years. So kind of looking a little bit more in depth over the past 20 years, I pulled some numbers. These data accounted for 46 cases, and close to 80% of those were individuals that were 50 or older. And then the really interesting thing where we diverge from the national scene are our US born individuals are 87% of those cases, compared to the national, which is only 28. And then our foreign born, we have a small foreign born percentage, and the national is 71. So a lot more cases in our US born Montana raised individuals. Looking at race and ethnicity, we see predominantly in our white and American Indian or Alaska Native populations, just a small percentage of Asian and Black or African American, and then ethnicity is pretty low as well. This just kind of shows the cases by race and that distribution, and how it's decreased over the years, kind of equally between white and American Indian as more efforts are going on. So there's kind of this misconception that we see all of our cases in our American Indian population, where it's pretty equally distributed. And then we have a smattering of foreign-born individuals in there as well. Most of the cases that we see here in Montana are pan-sensitive to TB meds. We've only had a couple with resistance, and the vast majority are pulmonary only, with some extra pulmonary involvement. And in recent years, we've been seeing some interesting ones that have been extrapulmonary, ocular TB, and others, which has been interesting. The primary reasons that individuals were evaluated, the majority had TB symptoms, and then from there, it was either incidental lab results or abnormal chest radiograph. And I would say in recent years, that's been more and more the case. We're finding cases very early in disease where they may be showing no symptoms or very few, and then smear negative, culture positive cases. Some of the recent estimates of transmission for Montana, what we've submitted to CDC, the estimate is over 90% of our cases are not attributed to recent transmission, but individuals that have had LTBI and converted. So really the reason why we want to address this large pool that's contributing to our active cases. Those are some references that you guys can look at, and my contact information. So without further ado, we'll go into hearing from Dr. Bob Belknap. We're really happy to have him with us. Dr. Belknap is the medical director of the TB clinic at Denver Health, and a principal investigator in Denver for the CDC-funded TB Trials Consortium and TB Epidemiologic Studies Consortium. He is also currently the chair of CDC's Advisory Council for the Elimination of TB. So go ahead and stop sharing my slides and turn it over to you, Bob.
Great, thanks so much, Ryan, and thanks for having me. You said my name is Bob Belknap. I'm an infectious disease specialist here at Denver Health and the director of the TB clinic. I've got no conflicts or disclosures. And so I like to sort of give the key points up front so you know what I'm going to talk about and what I want you to leave with. And I'll go through these as I go through the slides. But the first is, who should be evaluated for latent TB infection? And really the commonest risk factors and things we think about are where have people lived? So have they lived where they could have come in contact to someone who had TB? And in most of the US, the best surrogate marker for that is where people were born. That's not perfect. There are people who were born in the US and lived outside the US. There were people who were born outside the US but spent very little time wherever they were born and moved as an infant to the US. And so the time matters, but where people live, if someone had known contact to a person with active tuberculosis at any time in their life, with pulmonary TB specifically, that's a risk factor. And then immunosuppression. Immunosuppression is a little tricky because just being immunosuppressed in and of itself isn't going to be a risk unless you're immunosuppressed and you had contact. Since it's hard to know, we generally recommend if someone is someone is going to become immunosuppressed and with some more specific types of immunosuppression, often TB testing is important. And then we're going to go over the steps and tests for diagnosing TB. And the bottom line takeaway here is that the interferon gamma release assays, the blood tests, are preferred over the skin test. A chest x-ray should be done for anyone with a positive test regardless of symptoms. If someone has symptoms, they should get a chest x-ray regardless of the result of the blood test. And then if you have an x-ray that's abnormal, then to make sure that to send sputum, even if the person doesn't have symptoms. And then we'll talk about the preferred treatments. And they really are two in the US that are shorter course therapies than what we traditionally had. So the traditional regimen was isoniazid for 9 months. But really now, rifampin daily for 4 months, or isoniazid and rifapentine once weekly for 3 months are preferred treatments. So I always like to include examples where I can in talks. And so this is an example of a patient who we saw just this year, 24-year-old, originally from Ethiopia, and was being seen in medical care for a change of status immigration exam. This person was asymptomatic, did have a positive quantiferon and a negative HIV test, and the chest x-ray that you can see to the right, and I put an arrow just to highlight because it can be a little subtle, especially when taking x-rays and putting them into PowerPoint, but it was noted that there was some opacities in the right upper lobe apex, different than what the left apex looked like. And so the health department that was seeing this person collected sputum for smears and cultures that were negative, and then tried to get the person back for LTBI treatment, but there were challenges, lots of sort of competing priorities, and unfortunately this person never got treated. And so, fast forward 2 years, and they're seen for a cough, and they get a chest x-ray, and the radiology impression on the chest x-ray is dense right upper lobe consolidation, suspected pneumonia. Follow-up x-rays are recommended after antibiotic treatment. And so the primary care physician got that information and prescribed azithromycin for pneumonia. 3 weeks after that, not improving with the azithromycin, the person went to an urgent care, and at the urgent care got a SARS test that was negative, and was again diagnosed with pneumonia. No x-ray was done, and a prescription for doxycycline was given. 6 weeks later, and 6 weeks after that initial chest x-ray, the person is hospitalized, and I specifically put word for word what the impression on the x-ray was. What I left out, because I don't think it was seen by the primary care physician, was the description. And so this was the x-ray that had that impression of a dense right upper lobe consolidation. And what was also included in the findings, but not included in the impression, is that there was a 3.5 centimeter cavitary lesion in that upper lobe. We actually were since able to contact the radiologist and talk to them about this and why they didn't include the mention of the cavity or anything about tuberculosis. And the radiologist was very focused on the fact that there was no fluid, and they were had been either trained or were convinced that a fluid level was indicative of TB, and without that, it wasn't that high in their differential. And so this is how that x-ray changed over the 6 weeks. So the initial x-ray to when the person was hospitalized, and what you can see is that cavitary area has gotten larger, and the lung has, that right upper lobe has become more destroyed and retracted. And so there's been, as you might expect, over a month and a half, more lung destruction. And there's also now infiltrate in the left lung, so you can see some opacity in the left lung that wasn't there earlier. So it's been written about and recognized that a really unfortunate impact of COVID, along with all the many challenges that we're aware of, has been the misdiagnoses and delayed diagnoses of tuberculosis globally. And so this was, just highlighting a article that was in the New York Times back in August of 2020. So this is not, it's not a new recognition, but unfortunately still a challenge. And so what do we know globally? So we know that about 1/4 of the world is estimated to be infected with TB. And roughly 10% of those people will develop active TB sometime in their lifetime. And what that works out to mean is we get about 10 million people with newly developing active TB every year, and about 1.5 million people die from TB. Prior to COVID, tuberculosis was the leading infectious disease killer in the world. It had surpassed HIV/AIDS several years prior. It's even when you take into account people who have both HIV and TB. And unfortunately, more people are estimated to have died from TB in 2020 than in 2019, which is the first time in 2 decades that the World Health Organization estimates that was the case. And the reason for this is lack of access to TB care, where resources have been shifted to address COVID, lack of recognition with the overlapping symptoms, the similarity between COVID and TB. So I mentioned that one of the biggest risk factors is where someone has lived, and this map from the WHO shows incidence rates, so rate numbers of cases per 100,000, and you can see sort of where the hotspots are. Certainly areas that have the overlapping pandemics of tuberculosis and HIV have the highest rates. If we looked at a different map, if we looked at prevalence of TB, the countries that have the most people have the most number of cases of TB each year, and so that's India and China. And as Ryan already pointed out, we've seen a decline in TB now since the early 1990s, and it had been fairly gradual recently and appeared to be plateauing until last year, where we saw a roughly 20% decline. And in looking more deeply at this, it really appears that this is probably missed diagnoses and not that there was some functional change, even with changes in patterns of immigration and other factors that happened as a result of the COVID pandemic. It still appears that a lot of that drop was probably due to misdiagnoses and people, quite frankly, that may have died from a respiratory illness and maybe they had COVID, but they also may have had TB. When we look at the rates of by race and ethnicity, you can see it's different among non-US born versus US born persons. And so one of the risk factors that Ryan highlighted in Montana is still among the American Indian population there. Some improvements, which is fantastic. And then the second, for your population, second highest rate is among whites. And so, knowing that the population diagnosed in Montana is, it's a different demographic than what's seen nationally, I think highlights the importance of really understanding where people have spent time. I suspect many of the folks, the Caucasian people diagnosed with TB probably lived somewhere outside of Montana where TB is more common, and that was really their risk factor. And just to not spend too much time, because Ryan showed this slide, the reason it's so important to know that recent transmission is relatively uncommon is that means that there's an opportunity for us to prevent people from getting sick from TB. So some things we know about TB and the general public understands this better now than they did pre-COVID. Tuberculosis is transmitted through the air, small particles called droplet nuclei that can stay in the air for many hours. In order to infect, and this is different than COVID and other viruses, tuberculosis actually has to reach the alveoli. And so if you were to just end up with TB in the nasal mucosa or upper respiratory tract, you wouldn't get infected. It's got to get all the way down deep into the lungs. And then from there, once the TB does get in, one of the first things that happens is our immune system attacks and engulfs the tuberculosis. And it carries the TB then from the lungs into the lymph nodes and from the lymph nodes into the blood and throughout the body. And tuberculosis in that way ends up in what are called granulomas. And granulomas are collections of immune cells that are meant to contain TB. And we generally do this very well. And the majority of people who get infected with TB, all of this happens and they have no awareness of it. There's no symptoms that go along with this. The thing that our body is not very good at is eliminating those TB bugs. So TB has evolved and adapted the ability going back millennia to be able to survive inside of us without causing symptoms for months or years or even decades. And so we recognize that tuberculosis, we often talk about it as a dichotomy of people, or you could say that people either don't have TB infection, they have TB infection and it's latent, or they have active disease. We recognize that it's probably more complicated than that, that there really is a spectrum, that There are probably people who get exposed and maybe even get infected but clear it. We don't have a way of determining when or if or who those people might be. We think that a quarter of the world that is infected, those are the people with latent TB infection if they've never been treated, and those are the people from whom active tuberculosis develops most of the time. So it's important that we know what we're talking about when we say latent TB infection and what is the definition of that. And so this is the definition that's been developed by the public health experts and the epidemiologists. And so it includes laboratory and clinical criteria. So laboratory criteria is you have to have a positive test. And that could be a tuberculin skin test or a positive interferon gamma release assay. And then clinical criteria, which says you have no signs or symptoms of active TB, and that no signs and symptoms includes having a chest x-ray that is without any abnormalities, or if it is abnormal, that there's been a workup and active disease has been excluded. So back to then who's at risk and who should get tested. So as I mentioned in sort of the opening and the takeaways, we think about risks in sort of three big categories. The first is if someone had known close contact with a person with infectious, and by infectious we really mean pulmonary tuberculosis, at any time in their life. And so it doesn't matter, if the person is 50 now, but they were contact when they were a child, they're still at risk if they've never been diagnosed or tested, diagnosed, or treated. My own experience with that is that's a relatively few people who have that history and know they were close contacts. For most people, their risk of TB is where they live. And so we look at, as a surrogate, the easiest available one is where people were born, but also asking where people have traveled. And that could be, time spent in the military or volunteering, or we've seen students who have lived abroad for a semester, and that's their risk factor and where they likely got exposed to tuberculosis. And it turns out that the map of the incidence I showed you, tuberculosis is really, really common in most of the world. And so understanding that if someone has spent time living outside the US and in one of these areas, that is a risk. And then the last is that current or planned immunosuppression. We know that HIV has been associated with reactivation tuberculosis really since HIV was identified going back to the 80s. TNF alpha blockers, another big risk factor that we recognize, even more so than other biologic agents that are being used for rheumatologic conditions and cancer treatments and other things. The TNF is an important immune modulator to keep tuberculosis under control and effectively contained in granulomas. And then transplant. So this is meant to be this is not the entire list of immunosuppression, but some of the big key ones. So certainly bone marrow transplant, but organ transplant as well with immunosuppression. And I included a link here to a TB risk assessment form that Ryan and the folks at your health department of Montana have developed. And so as a resource, if you're looking to try to implement something that's relatively easy to screen, who has risk and who should be tested. So we really recommend that that people only be tested if they have a risk, because the performance of these tests, just like any test, if you test low risk people, you end up getting more false positives than real positives. So, but if you have someone at risk, there's three options for tests, sort of two categories. So the tuberculin skin test, also known as the PPD, many, if not everyone on this call has probably had this at some point in time. And then we have the interferon gamma release assays, and there's two of those commercially available, T-spot and quantiferon. All of these tests involve exposing the immune system to TB antigens and measuring a reaction. With a skin test, that reaction is in the person with the measurement of induration. With the blood test, it's measuring interferon gamma that's produced. So what do we know about PPD used for the tuberculin skin test? Well, it's a mixture of lots of different things. So it's denatured but soluble proteins and peptides. PPD is produced by autoclaving Mycobacterium tuberculosis for several hours. And you can see it's mostly proteins, but then also nucleic acid and carbohydrates. And there's a lot of overlap between the components of PPD from M. tuberculosis and some non-tuberculous mycobacterium, particularly Mycobacterium avium. And how this manifests in test results is that the tuberculin skin test is much more likely to be positive in someone who's received BCG vaccine. And so this was an evaluation, was one of the studies that the TB Epi Studies Consortium was involved with, looking at the performance of the tests in a mostly non-US born population and in people who were from countries where BCG is still used. And you can see, so BCG is typically given at or just after birth. Its benefit is that it protects the young children from getting the most severe forms of tuberculosis and dying of TB if they get infected. And so that's the reason why shortly after birth in the under 2-year-old, you see a much higher rate of or proportion of positive skin tests. And then it declines the kind of farther out you get. And then it tracks with age. And that makes sense because in this particular study, people were being enrolled, mostly recent immigrants to the US. And so the older someone is at the time that they move here, that's more time spent in a country where TB is common, so more opportunities for exposure. So the skin test tracks with the blood tests, but you see the gap never closes completely. And we think that gap is really what we're seeing as the effect of BCG. Versus the interferon gamma release assays, they're not perfect, but they are pretty good. The antigens that are used are in all of the forms of tuberculosis that make up the tuberculosis complex, and that includes Mycobacterium bovis. These antigens are not in any of the strains of BCG that are used for vaccination. They are in a few of our less common non-tuberculous mycobacteriums, Mycobacterium kansasi or marinum or soldi. So if you happen to have someone who is suspected of any of those infections or proven to have any of those infections, if they have a quantiferon or T-spot, it's very likely to be positive and doesn't represent TB. So what are the big advantages of the blood test over the skin test? Well, one is that it's a single visit. So you don't have to have someone come back 2 to 3 days later to read the results, to feel the arm and see if there's any induration there. I already mentioned that it's the advantages over BCG. The results are available in about the same time frame as a skin test. You know, it can be as quick as a day. It might be a few days depending on the lab and how frequently it's run. And then a huge advantage is the fact that the results are reported electronically. One of the greatest challenges that we never fully overcame with the skin test, even with electronic medical records, is it can be really challenging to find a result even if someone had it done, whereas the lab tests are much easier to actually locate. So what does it look like if you're going to do this in practice? And so again, it starts with identifying who has risk for TB. And then if they have risk, doing a test, but also doing a symptom review at the same time. One of the big challenges and errors that we continue to see is someone has symptoms and the person does a TB test to work that up. And unfortunately, neither the blood test or the skin test are very good at ruling out active disease. The skin test misses 25 or 30% of people with active TB have a negative skin test. And the blood tests are better, but still will miss 10 to 15% of people. We think the reason for that is that those immune cells that you're trying to stimulate with the antigens from the blood or under the skin aren't there. They're probably wherever in the body, wherever, trying to fight TB. And so you can misdiagnose someone, and we don't want to do that. So So if we have someone without symptoms, ideally we do a test. If that test is positive, they should get an x-ray. If the x-ray is normal, again, it's always, want to do a double check and make sure they're not having symptoms. And if they don't have symptoms, then that's the person who we want to consider for LTBI treatment. And the last thing I wanted to show you for the sort of diagnostic that you may find if you're testing people, and this gets a little bit back to the pathophysiology. This is an example of what's called a Ghosn complex. And what that is when that initial infection occurs with TB and the TB gets into the alveoli and then it's carried to the lymph nodes, in some people that the healing from that can lead to a scar and calcification. And so Ghosn complex is a calcified granuloma, so you can see that on the CAT scan, and calcification of the lymph nodes. And so this is not concerning for active disease, but it's supportive of the fact that this person was infected with TB and has contained it. But unless they're treated, they're going to be at risk for developing active TB later in life. So let me just pause there and see if there are any questions. And I can't see the chat when I'm in presentation mode, so I don't know if there are any questions in the chat right now.
Not yet, Bob, but folks, feel free.
Yeah, absolutely. Or if you're comfortable, come off of mute and ask questions. Either way is fine with me. I'm going to shift though from the diagnosis to the treatment a bit, and I'm going to start this section off with another example. And so this was a 26-year-old female who was originally from Mongolia, and she was diagnosed with latent tuberculosis infection during pregnancy. And postpartum, she followed up, and she was started on the once-weekly INH rifapentine. But about a month in, she really wasn't loving it. She reported some nausea and some dizziness and a rash and some itching. And so we changed her to rifampin. But after one dose of rifampin, she said she had itching again, and she stopped. And 5 years later, unfortunately, she developed symptoms and came back to us and was found to have a large cavitary lesion and smear positive pulmonary tuberculosis. And so this was unfortunately a missed opportunity for prevention. And I'll talk maybe a little bit about the side effects she experienced and some things we might have tried to manage through that. I will say that we've been able to start her on standard treatment, and she's tolerating the rifampin now that she didn't tolerate the one dose she had previously. And so the simplified schematic of this is that the majority of people, 88% in the US, go through a period from latent TB infection to active TB. Many of them have risk factors associated with immunosuppression, but many do not. And what we're looking to do is identify the people who have latent TB infection, treat them so that they never develop active TB. So what should you do at first? So you diagnose someone with latent TB. I know I've said this a couple times already, but always want to emphasize the importance of ruling out active TB. So getting a chest x-ray, if that chest x-ray is abnormal at all, even if it's subtle, like the very first x-ray I showed that was sort of subtle upper lobe opacities, you want to get sputum. We've seen people like that grow TB, and we would not have wanted to put them on a single drug or even the 2-drug intermittent regimen for when they actually had active TB. It's always important to ask about a prior history if people have ever been treated for active or latent TB, and then we assess for risks of toxicity and drug interactions. The toxicity risks are mostly related to liver disease. So if people have known underlying liver disease or are at high risk for liver disease, maybe because of alcohol use, then that's something we want to take into consideration before starting medications. And then drug interactions. So both rifampin and rifapentine, one of the things that they do in the body, it's not really a side effect per se, but they increase our liver enzymes and increase our ability to metabolize a lot of other drugs. And so it's important to look at what other things someone is taking and consider the drug interactions. Some interactions are not contraindicated. It just is important to be aware of them so that, that we can monitor and adjust other medications if needed. A helpful tool for figuring out somebody's risk is an online calculator that was developed by some folks in Montreal that allows you to put in a skin test if they had it, a quantiferon, or really that's, a T-spot would be the same for that. If you have it, their age at immigration, if they're not from the US, what country they were from. It even includes then within country some of the state and territory information. And then it has down lower on the screen their risk factors for reactivation. So things like HIV and diabetes and smoking. And then you plug those in and hit enter, and it will tell you the likelihood that the positive test is truly positive. And in this case, with a positive skin test, positive quantiferon, it says is 100% positive likelihood of being TB infection. And then it gives you an estimated annual risk of reactivation and a lifetime risk up to the age of 80. Our approach in Denver has been roughly considering a risk of 3% or greater estimated lifetime risk for when we will recommend latent and offer latent TB treatment to someone. And then when we do offer treatment, we talk about the options. There were guidelines published just almost not quite 2 years ago now, February 2020. First update to LTBI treatment in 20 years. It took a long time to get it out, but we were glad to have it done. And in those guidelines, the recommendation was to use short course rifamycin-based regimens. And the reasons for this is that they really are better tolerated, and treatment completion is higher with these than it had been with isoniazid that had been the standard for about 50 years prior. And so it's rifampin daily for 4 months or INH rifapentine once weekly for 12 weeks. There's a third regimen that's listed as preferred. It's INH and rifampin daily for 3 months. There's less data overall than the other two regimens and less experience with that in the US. It's included because there is some data, and it is a regimen that's used outside of the US and particularly in the UK for treating LTBI. So wanted to include just a little bit about our experience with this, and we published a study just was in CID last month on our experience with treating adult patients. And mostly what we do is we offer them the option. We say, here are the options, and we include INH in that. And we say that our preferred and our recommended regimens are either the once weekly INH rifapentine, abbreviated 3HP, or 4 months of rifampin, abbreviated 4R. And our nurses mostly give people that information and allow them to choose. And we've seen that almost half of people choose, one or the other of the short course regimens. Some people say, I want to get done as quickly as I can, and I want to take it as few days as possible. So the once a week regimen sounds great to them. It is about 10 pills for an average sized adult. So it's a lot of pills at one time. Other people say, I can never remember taking it once a week, and I don't like taking a lot of pills. I'd rather take rifampin, and with the rifampin, it's usually 2 pills daily for the 4 months. And so the groups were not equal, and so we did see, there was likely some bias in our nurses in terms of who they were comfortable and how they offered it. And so the patients who got rifampin were older. They were less likely to speak English or Spanish. So they were, spoke some other language as their primary language besides English or Spanish. But, with that caveat, and when we controlled for those factors, and we looked at how people tolerated it, and we looked at treatment completion, we saw that our treatment completion was actually a bit higher with the once-a-week regimen. So we had 81% versus 67% with rifampin. And we saw fewer adverse events with 3HP, the once-a-week 3HP, than with the 4R. And so this hasn't changed our approach or practice. We think that the differences in the groups likely explains the differences in adverse events and treatment completion. But it reinforced our use of the once-a-week regimen and our approach to offering this to patients in this way, we think has been effective. And it turns out the once-a-week regimen is safe and effective in children as well. And so the largest study that looked at this one was published 6 years ago now, treatment completion, which is oftentimes higher in children than in adults anyway, likely because parents who agree to treatment are motivated to get their kids to complete. But we saw 88% were able to complete the once a week versus this was a comparison to 9 months of INH, and it was still pretty good overall, but less than with the once a week. So nitrosamines. I want to talk a little bit about something you may or may not have heard about. We were feeling pretty good when the guidelines got published in February of 2020. And then, of course, everyone knows what happened later in February and into March of 2020 as our world got upended by SARS-CoV-2. And then for those of us in TB, it was in June of 2020 when we first learned about the issues of nitrosamines impacting our rifamycins, and specifically rifapentine and rifampin. And that I just put in a brief timeline of events that happened there. So what are nitrosamines? So nitrosamines broadly is a class of compounds that really are pretty widely distributed in our environment. They're found in water and foods and in some medications. The foods we often think about are cured or grilled meats, but also dairy products, vegetables, and notably in some medications that have since been removed from the market, like ranitidine. And we know that nitrosamine impurities may increase the risk of cancer. The best known example for this is the N-nitrosodimethylamine, or NDMA. And NDMA was originally, a component in rocket fuel, and it was, subsequently discovered in valsartan and antihypertensive medications, and then in ranitidine. And so the FDA and other agencies around the world began developing guidelines and also requirements for manufacturers to look for these compounds in their medications. And when they looked for them in rifampin and rifapentine, they identified some nitrosamines. These are not NDMA, and they're not nitrosamines that we have any information on about their cancer-causing potential. So they found that these were there. And the manufacturers have been working since that time to find out what's the cause of it, how do they get in there, and how can they eliminate as much as possible. So what do we know about nitrosamines and rifamycins? Well, we know in general that nitrosamines are bad. We don't know the specifics about these two compounds, but nitrosamines are bad for people. We also know that treating tuberculosis without rifamycins is bad. Rifamycins are our best drug for treating active TB and our best drugs for treating latent TB infection. And so we know that there's risks if we were to move away from these and say for latent TB, if we were going to only treat with INH, or active TB, we were going to treat without the use of rifamycins. That has known risks to people as well. The risks of the nitrosamines we don't really know. The FDA has determined some levels that they're trying. They want the manufacturers to get the levels of nitrosamines below a cut point, and the way they determine that cutoff is they say we want it below a level that we think you could take this drug every day for 70 years, and it would not increase your risk of cancer more than 1 per 100,000. That's how they've defined that, and that's challenging for us because we know that we don't give these medications every day for 70 years. We give one of them for 12 doses and we give the other one for 4 months. And we know that the risk of cancer in general is already incredibly high. So separate from nitrosamines, the FDA has said to us in conversations, the estimated lifetime risk of cancer in men is 1 in 2, and in women 1 in 3. So that, you know, on the background of that, we're trying to reduce nitrosamines. Again, very laudable goal and important thing to do, but we have to, I think, frame it in the context of what are we using these drugs for. And so what do we not know? We don't know that the risk of these specific nitrosamines at different levels and for short durations. And we don't know if they carry any risk in special populations like children and pregnant women. So what is our approach here in Denver? We have really decided that the known risks from tuberculosis, from reactivation TB, and from INH for LTBI are likely much greater than the unknown and theoretical risk of these nitrosamines. And so I've included language that we developed and our nurses generally use, because they're the ones typically talking to the patients about the medications. And so we inform people about this, you know, that this has been found, that this exists, but we also inform them that still that, you know, the CDC, the FDA, and our clinic recommends the use of rifamycins for treating TB or latent TB, because they are the best medications. We don't offer them to people or recommend them to people who don't have risk. So we really think that we are giving people information that is important for them to know, but at the same time trying to balance that with what the real risk is. So I always like to come back to what it was I was hoping to communicate and that you walk away with from this talk. And so, you know, the 3 big categories of risk factors for latent TB infection, where someone's lived, if they've been in contact, or immunosuppressions. The steps and tests for diagnosing it. So the blood tests are preferred. Always get a chest x-ray for anyone who's positive or if they have symptoms, and then sputum if the x-ray is abnormal, and then preferred treatments for FAMPin or INH for FAMPin. And I'll stop there and see if there are any questions.
Hey, Bob, there's one really good question that came up. Jessica was asking, you talked about risk factors for TB testing, but what about those persons who are tested prior to starting a job, let's say healthcare workers, daycare, et cetera? Is there evidence that this is an effective use of screening? And I know this is one of your favorite topics, so it's an excellent question, Jessica.
It is, yeah, really great question. So the short answer is no. So the question is there evidence? So there's not good evidence. The baseline evaluation testing of people who are going to be starting a job in healthcare, I think is valuable, even though there's not great evidence. A few things that we do know. We know that the most of the examples where there has been made big exposures to TB in healthcare settings have often been from healthcare workers who had known positive tests and weren't treated. And so that there is that opportunity when people are entering a field where they're going to be taking care of individuals to actually screen them and get them treated. And then it's also, you know, the risk management side of things from occupational health providers is, if a person working in healthcare were to get exposed, you know, we need to know and want to know, did their exposure as part of work lead to infection or not? And if they don't have that baseline test, we wouldn't be able to say a positive was due to a recent exposure or not. What really isn't valuable, and there's evidence to support the lack of benefit, is serial, which was usually annual testing of people who work in healthcare in the US. And so the guidelines around that changed a few years ago to recommend against regular testing of low-risk US healthcare workers. And so hopefully most of your institutions have made that switch.
Any other questions, you guys? Go ahead.
There's
Oh, there's
another
one.
Yeah,
Teresa, what are the potential risks of treatment with INH only? You did mention that a couple of times.
Yeah, the biggest risk is liver toxicity. And so particularly we see it, the older people are, the greater that risk becomes. And so, you know, recommendations even before 20 years ago, the recommendations going back to the 90s were to really only treat people under 35. And the reason, a big part of that reason was because of the increasing risk of toxicity with INH. Now, if someone over 35 had another risk factor, so if they had HIV or they had immunosuppression in some way, then it was recommended to treat them as well. But for people with no current risk factors for progression, if it was they just had a positive test, it was, you know, mostly people over 35 weren't offered treatment, and it was the liver toxicity. Most of the other things from INH are more intolerances than they are real toxicity. So people have GI upset even without hepatotoxicity, or headaches or fatigue. And it's just hard to get people to take 6 to 9 months of INH. You know, people just don't, you know, when they go in feeling well, taking a pill for that long that may make them feel bad, people just don't want to do it.
Yeah, I'd have to agree. I mean, I think it's good to remember, you know, INH still works well. It's still, like, there's times when you can't use a rifamycin-based regimen and it still works well. It's just we found these other two options work better and they take a shorter amount of time, right? And the side effects are less. So
I'll say anecdotally, when we offer it to people, the group that we've seen like typically now that may select INH are younger women who are on hormonal birth control. And so because the rifamycins decrease the effectiveness of birth control, there are people that say, you know, I don't want to have to deal with a barrier method or some other method. I'll take the INH. And I would say mostly when people choose the INH, they actually tend to tolerate it pretty well. I think there is something about being given that option and choosing it that helps people psychologically to tolerate minor things, as opposed to being, you know, feeling like they're being told they have to do something.
yeah. So here's just, I think it's re-emphasizing again, but Danielle is asking, should we be screening all employees on an annual basis, or just those who had positive quantiferins in the past? So I guess 2 questions, 2 clarifications.
Yeah. So no to annual testing of folks. Screening, I think of these as slightly different. I think that if you can do it, and having talked to a lot of occupational health people, not everyone feels they can. If you have the ability to screen people to find out, have they had known contact with TB, or have they done some work outside of the US in the past year that might put them at risk? You know, we say living outside the US for a month. That's kind of arbitrary to avoid the person who went for 2 weeks on vacation somewhere and outside the US, and their risk is very low. But there's nothing magical about a month. If you say, you know, I went and volunteered at a TB clinic in Haiti for a week, and no one wore a mask, that's a risk for TB infection. And so you should be tested, you know, after returning from that kind of activity. So if you wanted to screen people to find out, have you had any risk like that? And if they screen positive, then do a test, then absolutely. But just the blanket testing of all people working in healthcare in the US is not recommended. And then for people who have positive tests, the recommendation really is it was not new, but emphasized over the original recommendation from 2005, was those are people who should really be encouraged to take treatment. Those are the people that we see, you know, a small percentage of them, but those are the people who develop active TB and then, you know, end up causing transmission, or at least putting people at risk within a healthcare setting. So yeah, hopefully that answers the questions. I see.
Well, I know, Bob, you need to take off, and we still have a little bit more to go, so we won't.
I appreciate
Is that
it. Yeah,
right? Yeah.
I've got to run. I've got to run to another meeting. But thanks so much. I included my my contact information on the last slide. So if there are other questions, or Ryan, you know how to get a hold of me. Feel free to reach out and let me know. And yeah, good luck. Prevent TB.
Thanks so much, Bob.
So we'll go into the next presentation, and then after that, finish all the questions in the chat. They're great questions, so we'll definitely get to them. Ryan?
Perfect. Yeah, I just want to real briefly share my screen here. Go over some of the resources that we have available to folks that are tackling these LTBI infections, as well as some of the reporting criteria, because a lot that's now a thing. So really, this is just a quote from CDC, just really highlighting the need to, strengthen our current TB control priorities while increasing efforts to identify and treat latent TB infection among high-risk populations. So really getting at this well of 88% at the national level and over 90% here in Montana of individuals that are contributing to our active caseload, which are those with LTBI. So really trying to address this incidence rate that's plateauing. Our last effort to eliminate TB. So there were a couple of studies that were done looking at the prevalence of LTBI by county in the U.S. So you can see Montana, and I know we have a few friends from Idaho. There's some highlights there. Montana received its own prevalence estimates based on these studies. So that kind of what Dr. Belknap was talking about is we have this high incidence of folks that are latently infected, and that really is from 9 to 14.1 million individuals that are latently infected. And based on those estimates, Montana is estimated to have around 7,000 to 9,000 individuals with LTBI infection. It could be more, it could be less. We don't really know the real numbers, but based on these estimates, that's kind of where we're at. So in an effort to address these individuals that are infected with LTBI and contributing to that well, and since we're all kind of plateauing, latent TB infection was made a reportable condition starting the 1st of January 2020. I'll admit it wasn't the best timing given the global pandemic, but that was unforeseen. But these are the administrative rules of Montana, and where you can find these references. So 37.114.203 has the whole list of reportable diseases and conditions. And then there's a specific subchapter for TB. 1001 goes over that TB diagnosis, including LTBI. So really what counts as a case of LTBI, you can reference that there. And then required case follow-up reporting and contact investigation is also included there. I just included the links here as a resource for folks, but I really want to draw attention to the LTBI toolkit that I developed in preparation for this, making it reportable. These are the links, but you can also just Google, Montana DPHHS TB. It'll take you to our TB page, and then right at the top is a link for the toolkit. And within that toolkit, I tried to compile helpful resources for providers, for patients, educational materials for both, and just a lot of really useful things just for everyone. Right at the very top of that resource page is the Montana LTBI report form. And so that's everything that's required by local public health to report to the state and all the data elements that they'll be looking for. So if you do have a case and you get contacted by local public health, then these are the data elements that they'll be looking for that investigation. And then another highlight is the LTBI testing flowchart. So sometimes that can get a little messy. And for Montana, we're a low incidence state. And so we end up testing quite a few individuals that are really low risk for TB. And so this really highlights if you do get a positive test and they don't have those risk factors that Dr. Belknap covered so well, really emphasizing to get an additional test and only considering them positive if they have 2 positives for our low risk individuals. So there's that, and it kind of outlines that. And then the treatment guide for primary healthcare providers. This is a great CDC tool, covers all the regimens, those short course regimens, dosing, management for patients, and follow-up. So a great tool to have. And then as was mentioned earlier, the Montana Adult TB Risk Assessment Form and User Guide. So some really great resources. And then if you have any questions on any of those resources, please reach out, and I'd be more than happy to talk through, the development of those resources, or entertain any comments that you may have as well. So thank you.
Okay, so now we can go back to the question and answer. I think there were some questions from the chat earlier. Lisa, do you have them?
Yeah, I can see them. And hi folks. I realized I never introduced myself, but it's really good to see you all. I'm Lisa Chen. I'm the medical director. I'm a pulmonologist here at UCSF and run the Curry Center. And I'm just really happy to see so many people from Montana on here. And Brian, that was great. I want you guys to know what Ryan is doing here for Montana is so terrific, in that I know it's something new to have to report latent TB, but this is really going to push your curve from being really low down to, hopefully wiping out latent TB for the state. And it's really a fantastic move, Ryan. And I know that these kind of webinars that we're doing are helping to get you all on board. And a lot of you are actually, I know, both primary care docs and nurses from the clinics there, and you're the mover and shakers that are going to make this happen. So I want to recognize that. So the questions, there was one, Sue Hansen was asking about using INH. You heard of different food intolerances and maybe weird dreams on the medication. I have to say, I don't tend to see food intolerances so much on INH. I know that any of our TB drugs can sometimes, you can run the gamut of really just kind of mild GI, nausea, trying to get used to it. And that will often go away, but you're going to be watching them in case it turns out to be some kind of, a liver-based side effect. Can start out with mild nausea, but just the, general GI intolerance, but not necessarily a food intolerance. Weird dreams, less weird dreams, and more the small percentage of people can kind of have some CNS effects from INH. It's often, again, mild. Maybe they just feel a little brain fog. Some people have it a little more pronounced, and you might end up changing the drugs, but oftentimes, again, it's something that it's just an initial thing and then they get better. So it's just note it, follow it, listen to them if they're saying it's getting worse and offer them another option. Anyway, anything else you want to add in, Ryan?
No, I think more, not necessarily with INH. I think sometimes we see some strange intolerances with the 4-drug regimen. So not so many with the LTBIs. At least that's been my experience.
In April, you're asking what's the evidence for baseline. If the evidence for baseline testing is limited, then what's the rationale for a 2-step TST over a single test? Let's break this down a little, because I want to make sure, because it's easy, with guidelines that keep changing, or as we've learned more through the years, I want to make sure that we keep things straight. It's true, so you live in a really low incidence state, but we're still thinking there's your estimate was maybe 7,000 people with latent TB, and it's not always the same people as people move in and out of the state, and so baseline testing for healthcare workers makes sense, because if anyone is going to get sick and break down with TB, and it's going to take you a while to figure out, they're going to end up in a clinic or a hospital and potentially expose your healthcare workers. So you want to know where people started when they got hired. But it's a low enough incidence state that the new healthcare recommendations, recommend for almost any healthcare center at this point, you don't need to do annual TB tests like a skin test or quantiferin. You may do screening, like Bob was saying. You may ask them questions, and you do a lot of education now on this is what TB looks like, and these are when you should know what TB risks are in case you end up with those risks. But the actual tests annually aren't recommended. But baseline, when you're hired, just to know where you started compared to exposure. If you happen to have the bad luck of working the ER the day a bad case comes in that everyone thought was COVID. Now, 2-step test. Now remember, 2-step tests using a skin test is specifically because of how a skin test works. And if let's say I got latent TB when I was a kid, and I've never gotten sick yet, but I start to work in a hospital, now I'm much older. And if you put that first skin test on my forearm, my T cells, my immune cells might not quite remember it yet. My exposure was a long time ago. But if you place a second one, 1 to 2 weeks later, the first one has already kind of jogged the memory of my T cells. And so it's more likely to have a true response, like, oh, yeah, I saw it last week, and now I really remember I did see that antigen when you were young, and you get a true response. So it's based on how a skin test actually works, and it interacts with your immune memory cells in your body. Whereas a blood test doesn't have that interaction with those cells. And it's testing, basically the cells that you've drawn at that one time, and you're not feeding in an antigen into your immune system, and we haven't seen that booster effect coming from, 2 blood tests, because you're not giving the body any antigen. I hope that makes sense. But even the last clarification, for some of you might be confused, if you get an unexpected positive on a blood test in a low risk person, like Ryan was saying, in a low incidence state, it's wise to do a second test, because you find no risk factors that tell you why that person is positive, and you want to confirm that they truly are positive, because you're starting to run into the low positive predictive value when you start testing a low incidence population, and you want to confirm it, and you would probably believe the negative test in that circumstance. You're going to question them a lot about their history and really try to pick apart, is there any chance you could have been exposed? But if you really believe it's a low risk person, you're going to believe the negative test. If you get a second positive, then they just had bad luck somewhere, and you believe that they probably had TB exposure and now an infection. I don't know. Anything to add on that one, Ryan? It's a long explanation. Sorry.
Oh, that was great. Yeah, thank you for emphasizing the repeat testing. We run into that all the time. Like we have no risk factors. Why is this positive? Let's get another test. And then already since we've implemented this, we've had numerous individuals come up negative with the second one, and then they don't have to get a chest x-ray. They don't have to go through treatment unnecessarily. So it's helpful.
Yeah. I see a question from, well, I see the note, hey, Teresa, yes, your son got 9 months of INH back before, people were switched over, and I'm glad, you got your son food if he needed it. Jessica is mentioning, is there a way to differentiate between previously treated latent TB with an additional, so a second exposure, and have they been infected again? The bad news is we don't have a way to tell the difference between an old infection and a new infection. But it is true, a person can have the bad luck of getting infected a second time. And so you just really have to carefully look at that second exposure. Do we think that they're really at risk of having gotten infected again? Or are they someone who, if they were infected newly a second time, do they have a new risk factor for progressing on to active TB? So like in your population, is this a diabetic? Is it somebody, who's about to get immunosuppressed because they have arthritis? They're going to put on a TNF alpha blocker. I mean, any reason to worry about, boy, you got some chance that you just got exposed again. 2 other people converted their skin test, and you live in the same household and you have diabetes, you might actually talk about retreatment. But none of our tests can tell the difference between an old infection and an infection yet. Hopefully they're getting closer, but they're not there yet. Let's see, some more questions at the bottom. Some of you guys have to go see your patients. I see that. We currently get a quantiferin for all new hires. Would you recommend in changing that to just getting a quantiferin on those who identified risk factors on our new hire screening forms? Brian, I think all new hires still end up having to get at least one test, so you have a baseline test documented?
Yeah, it really comes down to just kind of covering your bases, kind of like what Dr. Belknap was saying, is you need to have that on file. You don't know if, like Dr. Chen was saying, if somebody's going to come in and potentially expose somebody. So if you had a baseline negative, and then, after they've been educated, maybe they go out of the country and all of a sudden they might have a risk factor, and they're like, hey, I have this risk factor now. Let's repeat a test just to make sure, I don't have an infection, and then they come up positive. That they haven't always been positive. It was either this incident that happened in the clinic, or that risk that happened when they were traveling, or what have you. But it also covers the clinic, that HR element, and you gotta dot your I's, cross your T's, and if you have that that negative on hire, if you don't have that on the flip side, then you can't say that you did your due diligence if a healthcare worker ended up becoming a case.
Oh yeah, I mean, actually, if I was a healthcare worker and I got and it ends up being that I got my TB through my work, I would want my hospital system to take care of me, but you can't prove that unless you show you were negative at the start and then you turn positive. So it's that kind of coverage. And I guess both sides are concerned about the liability, but you'd want to be able to say, this is where my exposure was. I don't have anything else. And you can compare it to my baseline. But there is a question here. What is the value of a quantiferin test that would lead you to believe it's indicating truly latent TB. Well, yeah, so there's a few things with your quantiferin, and that must be the test, the IGRA that's most commonly available for Montana rather than the T-spot. Yeah, okay. So one of the things with the quantiferin test is that, you know, you can read the results are written as positive and negative, but get used to looking actually at the values, right? So the cut point for positive is anything greater than 0.35. And so look at those values. And you know, if there are some nice studies of lots of healthcare workers, you know, and it tells you really, you know, if they're really high on that quantitative value, like over 1, you know, or 1.11, depending on whose study you look at. if it's really up there, it's probably truly a positive. But again, in a low incidence state, I would double check. You know, if you really, I ask a person, there's no risk, I would recheck and compare the two. But can you tell if it's, you know, a true just based on that? If sometimes if it's really between 0.35 and 1, some people call that, you know, kind of a gray retest zone, even if you're not in a low incidence state, but you're just, you know, screening people. And so I would scrutinize those low positives a little more closely than the ones that are, you know, way up there. So if you just start getting used to looking at those numbers, it'll help you. But it's true, you're not going to be able to tell the difference between a new infection though with that, for sure.
Yeah, the only thing I would say is that we tend to get a lot of positive values between that 0.35 and 1. And so it kind of further emphasizes, you know, if you've got somebody positive at 0.4, you know, it's so close to that cutoff. And then looking at those risk factors and like, okay, this is even more of a reason to retest this person because we're so close to that cutoff. And you know, occasionally they do come back positive, and then you just go with that because it's better to err on the safe side. But you know, oftentimes that can come back negative, and then you feel much better about that negative, right?
Yeah. Well, and be sure, you know, you guys, we're talking about healthcare workers here because a lot of the questions look like they're, you know, the baseline test for healthcare workers because of your exposure risk and the kind of work you do. But if you're telling me this is about school teachers, it's like, no, don't baseline test these guys. It's like, there's no reason in the US with our numbers that we should be baseline testing, you know, people who aren't in healthcare, who aren't going to have that risk. You're just going to get a lot of false positives. It's that they're, as a primary care clinic, if you're working in a primary care clinic, you need to be asking a person, what are your personal TB risks? And if you have one, that's the person who gets tested because they have a personal TB risk, but not because of their job. I'm not seeing any other questions. I think sometimes a really common thing is just talking about TB. Like, is anybody, I mean, any discomfort in how you even bring it up?
Yeah, also feel free to unmute and ask a question as well. You don't just have to do it in the chat now.
Yeah. Well, Ryan, these are your latent TB champions for the state. Any closing words for them? They're going to go out and conquer.
Yeah, no, they already are. It's great. But yeah, just know that my door is always open, and you know, if you ever want to talk about a test result or you've got questions on a regimen or really anything, you can always give me a call. If I can't handle it, our friends at the Curry Center are there to help us out. They have their warm line to consult on difficult cases. And so really there's resources available, and you know, we're available for you. So don't ever feel like you're, you know, in some rural location and you don't have resources, that we're here for you. So thank you everyone for attending.